Today I will discuss about the management guideline of malaria, which is very common in India and also in West Bengal, Kolkata. So can I share my screen? So today we will discuss about the malaria. The malarial disease is a basically protozoal disease, Plasmodium species, especially Plasmodium vivax, Falciparum, and Plasmodium ovale and Plasmodium malariae is the causative agent and transmitted by infected female Anopheles mosquito. So this is the life cycle of this Plasmodia. It has two parts. One is in the human body and other in the mosquito's body. So what happened when there is an infected person? The mosquito suck the blood and it contains the red blood. This gametocytes is enter the mosquito's body. Then it form a zygote, ookinete, and then it's go to the midgut of the mosquito and produce sporozoid, and this sporozoid is enter the salivary gland of the mosquito, and when this mosquito bite again in the non-infected person, this sporozoid entered their body, and then it enter in the liver, and then it multiplied and produce the merozoite. This merozoite enter the RBC, and ultimately its multiplication of done in the uh, RBC, and ultimately it damage the RBC and break down. Therefore, when there is a multiple number of RBC breakdown, there is a seizure or rigor. Still the rigor is happening and high fever is there. So that is the whole life cycle and mechanism of your malarial disease. Therefore in malaria there is a you have a anemia associated with it, low hemoglobin, and also high bilirubin, liver failure is there. So sometimes it's become complicated, and also high. Nowadays it has been seen that there is a low platelet count, thrombocytopenia, along with this. So diagnostic tool, how you will diagnose? There is a blood test. One is your microscopic or antigen based test. Microscopic, there are two type of blood smear produced. One is the thick blood smear, other is the thin blood smear. The rapid diagnostic test is basically a antigen antibody reaction test. We'll discuss in detail. So demonstration of the asexual form of parasite stain in the peripheral blood. If you do thick blood smear, it will give you this parasite, which parasite is there, and thin blood smear, it helps to identify the which type of Plasmodium is there. And rapid diagnostic tool also, it having some thick blood smear is a Plasmodium identification and asexual parasite for 200 WBC. It is very sensitive and inexpensive test, and require little bit experience to identify this parasite. Thin blood smear, specific identification and quantification of the parasites, and also you have in case of the severe malaria, it stages of parasite development can tells in your thin blood smear, and count PMN containing malaria pigment. So next come to the your Plasmodium dipsticks. So it is basically antigen antibody reaction. The rapid relatively, it is also not much expensive. There are two types, PF, HR, P2 is only for Plasmodium falciparum, but LDH based dipstick, it can identify the Plasmodium falciparum and other Plasmodium like Vivax also. But remember, it is not a quantitative test. Quantitative test means how much quantity, or in one field how much Plasmodium is there. If you can quantify, then you can understand the severity of the disease. And in antigen antibody reaction, it only gives you the data about whether cases is positive or not. So negative blood smear make diagnosis malaria unlikely, but remember, it is one negative test is doesn't mean the patient is not having the malarial disease. So you have to do subsequently at least you have to have the 3 negative tests. So every 12 hour or 24 hours you have to do in a test in a strongly suspected cases. So it is not like that you do one test and your stamp is a malaria negative case. I have come across few days ago one reference case that has been actually it is a the court case. The patient was admitted in the hospital with a history of fever, chill, and rigor, but they have started all the tests and they have not found the malaria. They have started treatment of typhoid and subsequently patient died. And before that, when the patient is very critical, intubated, ventilated, and transferred to other hospital where they have done the again done the malaria test and it become positive, and that was a falciparum malaria, and patient died in that hospital due to delayed treatment. And it was a negligence case from the previous hospital, and they have to give the hefty amount of compensation. So so therefore it is very careful when you are suspecting there is a malaria, so you have to do subsequent test. Okay, so now coming to the treatment part, the aim of the malaria case management is one is the anti-malarial drug. Second part is to give the support of the different organ and prevent deaths due to severe complicated malaria and prevent transmission of the malaria. So in uncomplicated Plasmodium vivax case, uncomplicated means there is a fever, rigor, but there is no dehydration, no other organ failure is there. So you can do this treatment on the OPD basis. The dose of chloroquine, you have to give 25 milligram per kg divided over 3 days. So first day you will give 10 milligram per kg, second day also you will give 10 milligram per kg, and third day 5 milligram per kg. Plus you have to give the primaquine 0.25 milligram per kg for 14 days along with the food after negative G6PD. Here the important thing is that you have to do G6PD test before prescribing primaquine, and there is a guideline is that if the G6PD is deficiency, primaquine to be given once a week, or if it is a severely deficit, then you don't give. In severe deficiency, you don't give. Or primaquine is contraindicated for pregnant or children patient. And the chloroquine resistant case, when there is a chloroquine resistant case, you can use artemisinin combination therapy along with primaquine. So we will discuss in details these things. So treatment of mixed infection, like if you have Plasmodium vivax and also Plasmodium falciparum cases, then All mixed infections should be treated full coverage of artemisinin combination treatment and primaquine 0.25 milligram per kg body weight daily over 14 days. The treatment of Plasmodium ovale and Plasmodium malariae in India, these species are very rarely found, but in Africa it is very common. And we will discuss about the regime. And mixed infection, in all cases mixed infection treated your Plasmodium falciparum plus primaquine, because in Plasmodium falciparum primaquine is not needed for the 14 days, but other in the vivax or ovale it needed for 14 days, because they enter the liver and they can stay for the long time. And they when there is a no there is no action of the chloroquine in the blood, they come out and they again produce the infection. So recurrent infection will be there if you are not giving the primaquine in Plasmodium vivax. So next come to uncomplicated falciparum malaria. So falciparum malaria, you know, it is a it has a very bad effect on the brain. They can easily transmitted blood. They can easily cross the blood-brain barrier. So they produce the neurological symptom. So in that case, you have to give the best is you start with artemisinin based combination therapy rather your chloroquine only. So artesunate is 4 milligram per kg body weight daily for 3 days plus sulfadoxine, and the sulfadoxine is 25 milligram per kg body weight, and primethamine is 1.25 milligram per kg body weight on first day. Or you can start artesunate plus amodiaquine, because sulfadoxine has some allergic reaction, some intolerance. So artesunate and the amodiaquine can be used plus primaquine. Remember, in the primaquine in a falciparum malaria cases, you have to give 0.75 milligram per kg. It is a 3 times of the Plasmodium vivax doses, but on the day 2 only, not in 14 days. So multi-drug resistant Plasmodium falciparum malaria, how will you understand it is a multi-drug resistant cases you are dealing with? If you're not getting response within 3 days, or having history, previous history of Plasmodium falciparum, and it was resistant to chloroquine or artesunate previous, then you can use the first line drug is artemether and lumefantrine combination. Artemether is 1.5 milligram per kg, and the lumefantrine is 9 milligram per kg. The BID dose for 3 days with food. Or if artesunate is positive, artesunate is sensitive but chloroquine is resistant, then you can use the artesunate. It is a very good drug, well tolerable, 4 milligram per kg. Here is a dose you have to give little higher, that QD means 4 times daily for 3 days. Usually we give twice daily. And mefloquine, this is a new drug. This is not very new drug. It is the drug orally available, 25 milligram per kg, either or either 8 milligram per kg QD for 3 days, or 15 milligram per kg on day 2, and then 10 milligram per kg on day 3. Second line treatment of imported malaria means this is when there is a first line is resistant or intolerance with the chloroquine, or you can give, because chloroquine has most of the queen has side effect that it create the QT prolongation, especially in the chloroquine. It's maximum the QT prolongation. So if there is a QT prolongation, then is a chance of VT or arrhythmia and cardiac arrest. So you have to be remember, when you are prescribing chloroquine in a malaria patient, you do ECG before starting your chloroquine drugs, and you measure the QT, and also after 24 hours it is mandatory to do ECG and again measure the QT. If there is a sign of QT prolongation, you have to switch off from the chloroquine to it's better to go for the artesunate. Quinine has also property to do a prolongation, and other drug is you can use doxycycline, tetracycline, clindamycin. In case of complicated falciparum malaria, complicated means more than one organ failure, either patient presented with a comatose, or patient presented with a seizure, or patient presented with a respiratory distress, ARDS like features, or renal failure. Then it is called complicated falciparum malaria. And clinical features already I have mentioned. There's convulsion, and there is a failure to feed, impaired consciousness, and the respiratory failure, low BP, circulatory collapse, anuria, renal failure, hemoglobinuria, anemia, thrombocytopenia. These are the sign when the organ failure is present. It is called complicated. And as usual, you will expect there is a hypoglycemia also is very common with malaria, lactic acidosis or metabolic acidosis present, severe normocytic anemia I mentioned, and parasitemia. If the field filled up with the parasites, then hyperlactatemia and renal impairment. These are the sign of the laboratory findings of complicated falciparum malaria. And as I mentioned, the decreased platelet count. In malaria, we ignore platelet count, but remember, if there is a thrombocytopenia or platelet count is less than 50,000, treat as a complicated malaria. Otherwise, there is a chance of bleeding and massive bleeding in the intracranial and can cause death. So when there is a organ failure in a malaria, it is emergency, and you have to admit the patient in ICU. You have to support the organ. You have to support the airway, breathing, circulation. If needed, intubation, ventilation is mandatory. And also you have to check the blood glucose. You have to maintain the blood glucose, both causing the malaria, causing hypoglycemia, also the malarial treatment, the chloroquine or quinine causing hypoglycemia. So remember, the glucose monitoring is more important here in treating the malarial patient. Unconscious patient should have, in an unconscious patient, you have to do lumbar puncture. Sometimes it is combined with bacterial meningitis, or the malaria can cause this coma. After rapid clinical assessment, confirmation the diagnosis, full dose parenteral anti-malarial treatment should be started without delay, and effective anti-malarial whatever is fast available. So here important thing, you have to give all injection. Anti-malarial treatment, what you will give? Artesunate. Obviously, it is the first choice. Artesunate you will give 2.4 milligram per kg start IV, followed by 2.4 milligram per kg at 12 and 24 hours, then daily if necessary. So artesunate, one is bolus, followed by 2.4 milligram 12 hourly, then daily if necessary. If it is unavailable, then artemether, or you can use quinine dihydrochloride, 20 milligram of salt per kg infused over 4 hours, followed by 10 milligram per kg infusion. Remember, when you are prescribing quinine, you have to monitor the QT, you have to monitor the CVG, because it is causing potent hypoglycemia. Okay. So give parenteral anti-malarial in the treatment of severe malaria for minimum 24 hours, and therefore thereafter complete treatment by giving complete course of either artesunate plus amlodipine, or there are multiple option. You have artesunate plus sulfadoxine plus primethamine. It is the commonest used combination forever. There are multiple combination option you have. You can use any one of them. And after parenteral administration therapy, patient will receive full course of air specific oral artesunate combination therapy for 3 days. Who receive parenteral quinine therapy should receive oral quinine 10 milligram per kg body weight 3 times a day for 7 days. There are something you don't do in a severe malarial case management. Do not use corticosteroid in a malaria patient, and do not give intravenous mannitol for reducing intracranial pressure. Do not use heparin as anticoagulant, and administration of adrenaline or overhydrate. So the thing is that corticosteroid is absolutely don't give, and don't use anticoagulant. There is a chance of bleeding risks because it is a complicated case, and administration of adrenaline and the overhydrate. So whenever you there is a need of fluid, but you have to measure the actual requirement. Otherwise if you give maximum overdose, fluid is a drug. If you give overdose, it causes lung congestion and the pleural effusion, ascites, because the capillary leaky capillary is there in a severe malarial cases. So you have to be very careful on that. And there are adjunct therapy for severe malarial cases, like if patient is comatose, cerebral malaria, then you have to take care of the brain. So you have to prevent the secondary insult of brain, like hypoglycemia, bacterial meningitis, avoid harmful treatment, and you have to take care of the other parameters, you have to intubate, ventilate. And hyperpyrexia is one of the commonest manifestation. So you have to take care of the fever by giving paracetamol. But remember, if sometime fever increase more than 104 degrees Celsius, so at that time you have to do a rapid cooling by giving ice on the strategic point of the body, like in the axilla, in the groin. And also you can give the cold water bath in a malarial patient who has a hyper pyrexic, because if the temperature is beyond certain level, all the enzymatic activity has become hampered, and there is a causing a severe acidosis and the collapse of the cardiovascular system. So you have to be very careful about that. If there is a convulsion, you have to give the anticonvulsing agent. But remember, if you using the phenobarbital to reduce the you break the convulsion seizure, then you have to take care of airway, because phenobarbital has sedative effect. If you are using the diazepam, then also you have to be very careful, and you have to take care of the hypoglycemia. If there is a hypoglycemia, you have to correct it as early as possible. And severe anemia, if hematocrit for less than 20, then you have to give either packed cell or whole blood cell, which is available. And acute pulmonary edema, then treat according to that, uh, uh, as you like, treat the patient of ARDS, uh, propped up the 45-degree, give oxygen, give diuretics, stop intravenous fluid, intubated, ventilated. If there is a renal failure, then you have to give supportive treatment. If patient is anuric, you go for the dialysis. So malaria is not a very simple disease. So remember things that you have to do everything according to patient requirement. So fluid therapy, again, it is very important in case of your malaria. In a severe cases, you need fluid to maintain the blood pressure, but you have to monitor the requirement of the fluid by taking various method, capillary filling time, IVC filling, IVC collapsibility. So so fluid balance salt solution fluid is better than your normal saline or ringer lactate. But regarding the fluid, you have to be careful. So if the patient having the coagulopathy or spontaneous bleeding, then you have to be very careful. You give injection vitamin, transfuse the fresh frozen plasma if available, or cryotherapy if available. And metabolic acidosis is there. Then you have to identify the cause of the metabolic acidosis, whether it is due to hypovolemia, whether it is due to septicemia, and treat accordingly. Next, if the patient is shocked, then either it is a septic shock or cardiogenic shock, you have to identify and you have to treatment accordingly. And this patient are vulnerable to develop secondary infections, especially aspiration pneumonia in a comatose patient or ventilated patient. So along with the malarial treatment, you have to do treatment of pneumonia. Next, another thing is the management of the treatment failure. So there are certain group of patients where you are using this anti-malarial drug like chloroquine or quinine, but still after 1 week or after 2 weeks, still there is a smear positive for this Plasmodium falciparum. Then what you do? So either you have to, then this is a two category of patient. One category patient, you have given the full treatment. In spite of that, there is a malaria positive. So that is called treatment failure. Or some group of patient, they have taken the drug and they have afebrile and they have discontinuation of the treatment. So they again positive within a week. So then this group, this two category of patient, and or some patient having the resistant or poor adherence or inadequate drug exposure. So consider them as a treatment failure, and you have to, so failure within 14 days, then start this thing, or if more than 14 days. So alternatively, you can start artesunate combination therapy, or artesunate plus tetracycline or doxycycline combination, or quinine plus tetracycline and doxycycline combination. So if the patient come failure after 14 days, so patient initially treated with malaria, they go home, but again after 14 days there is a recurrence of fever and parasitemia more than 2 weeks after treatment, could result either from recrudescence or new infection, this distinction can only be made through parasite genotyping by PCR. And consider new infections, especially area high transmission. So if the patient having malaria and if you have treated, there is no guarantee you will not get new infection with after 14 days. So it is very difficult to say whether it is a treatment failure or whether it is a new infection. So you have to do PCR, then you can probably say that it is a new infection or it is a previous infection. If the failure is a recurrence, then first line treatment should still be effective in the most cases. So if it is a patient non-compliance, you can go for the first line treatment. But however, reuse of the mefloquine within 60 days, first treatment is associated with increased risk of neuropsychiatric reaction. So it is better to avoid mefloquine in a treatment failure case. Hey, আমার চশমাটা দাও না, কখন বললাম? Treatment in a specific population and the situation, like treatment of uncomplicated falciparum cases in a pregnancy. So another common patient we found, that is a pregnant patient with a malaria. So always remember, pregnant patient is a special group of patient because most of the drug you can't give because of the teratogenicity. Pregnant and the lactating woman is a special group of patient. So if it is a first trimester, so you can't give quinine. First trimester, it is better to give quinine salt 10 milligram per kg 3 times daily for 7 days. Or if it is a second or third trimester, then artesunate combination therapy as per dose schedule given above. Primaquine is contraindicated in pregnancy. In a lactating mother, recommended anti-malarial treatment is including your artesunate combination therapy, but primaquine and tetracycline is a contraindicated. Now, another group of patient who is a traveler returning from non-endemic countries with uncomplicated malaria. So then you can give atovaquone plus proguanil as combination, or artemether plus lumefantrine combination. In a severe cases, severe malaria cases, treatment of anti-malarial treatment traveler is the same regime like complicated falciparum malaria. And this is a special group of patients where malaria associated with HIV. So why it is a special group? They are all already on antiviral, different antiviral. So, and also there is a unstable transmission area HIV infection, and it makes more complicated of reaction, and they need prompt treatment, otherwise they develop the much more complication. So you remember that certain drugs you can't use in a HIV patient, like patient HIV develop malaria should receive prompt and effective anti-malarial drug. But if the patient on co-trimoxazole, trimethoprim plus sulfamethoxazole prophylaxis, it is given for PCP prophylaxis, then please do not use sulfadoxine pymethamine combination to them. It causes a bone marrow depression. And patient with zidovudine or efavirenase there, so please avoid amidaquine or amidaquine containing artemisinin combination therapy. So amidaquine you will not give in a zidovudine patient. There will be drug-drug interaction. Now, regarding the transmission of the malaria, malaria can Transmission. Malaria can be transmitted through blood by needle stick infection, or during organ transplantation. So the clinical feature management, this case are same in naturally occurring infection, and radical chemotherapy with primaquine is unnecessary for transfusion of transmitted Plasmodium vaccinum, Plasmodium vivax, and Plasmodium oval infection. So malnutrition, one of the commonest problem. If there is a malnutrition in a malarial patient, then challenging of drug dosing, and also because you all know that malaria causing the your low appetite. If there is a malnutrition is there, it will prolong your disease. Now, in sum up, the microscopic result within 24 hours. If suspected malaria case, then take slide and send microscopic examination. If positive Plasmodium vivax, then chloroquine 3 days plus primaquine 14 days according to weight, and positive for Falciparum, then artesunate combination therapy kit for 3 days and primaquine single dose on the day second. If positive for mixed infection, then better give artesunate combination therapy plus primaquine 14 days. If it is negative, then no anti-malarial treatment. But remember, if it is negative and highly suspected case, you have to repeat at least twice. So microscopy not available within 24 hours, and monovalent rapid antigen is there. Then you do rapid antigen test, rapid antigen for Falciparum malaria. Then the same regime is negative. Then highly suspected, go for the chloroquine treatment, and if confirmed, then according to species you go for the regime. If it is low transmission area, wait for slide result, give chloroquine. If positive for vivax, same regime. If positive for Falciparum, the treat with artesunate combination therapy for 3 days, then primaquine single dose on the second day. Okay, so again this same thing. Okay, and short-term chemoprophylaxis up to 6 weeks is for whom you will give chemoprophylaxis. Chemoprophylaxis should be administered only in selected group in high Plasmodium falciparum endemic area. Use personal protection measure including your net, and long-lasting insecticidal net is available. Is always remember, prevention is better than cure, and it is more important for the military or paramilitary force for high Plasmodium falciparum endemic area. They can take the chemoprophylaxis. There are short term or long term. Short term up to 6 weeks, long term is more than 6 weeks. Either doxycycline 100 milligram once daily for adult. Children is contraindication, and more than 6 weeks, mefloquine weekly 250 milligram is recommended. Chloroquine and mefloquine resistant Plasmodium falciparum cases, if it is endemic area and found that chloroquine and mefloquine resistant cases, so better go for the prophylaxis with atovaquone or proguanil according to the dose, and take daily at the same time each day while in malaria's air. Continuous 7 days after leaving such area. Thank you. I have taken reference from Harishan and WHO guideline. Thank you. Thank you for patience hearing. So I think one question is there.
Sir, we have one question here. In hemolytic jaundice.
Hemolytic jaundice, primaquine can be given or not. So remember, if there is a hemolytic jaundice along with a malaria, so I have already mentioned during the mechanism of the life cycle of Plasmodium species. So hemolytic jaundice is quite common with the malaria, but if it is a Falciparum or it is a vivax, there is no contraindication of primaquine unless G6PD deficiency is there. If G6PD deficiency is there, you can't give the primaquine. Primaquine basically is kill the Plasmodium in the liver. So you have to give primaquine unless it is contraindicated. Next question, please.
So
Any
there's no
question from audience?
Yes. I request all of you, please, if you want to put up your opinion, or if you having any inquiries
You
or
can
queries.
unmute your you can unmute yourself and you can ask question. If there is no question, then we can conclude the session.
Yes, sir. I guess there's no question yet. So we will conclude the session for today. Thank you so much, sir. Thank you, all of you. Thank you.